So, good afternoon. My name is Meshak. I'll be taking you through gastro-esophageal reflux disease. And I'm Meshak. So, gastro-esophageal reflux results in heartburn and usually affects around 30% of the general population. Some of the factors that are associated with gastro-esophageal reflux, we have pregnancy due to pressure, it increases pressure. We have obesity, we have ingestion of fats, chocolate, coffee, and alcohol. We also have drugs, that is antimuscarinic, calcium blockers, and nitrates. We have large meals, we have systemic sclerosis, treatment for achalasia and hiatus hernia, and also cigarette smoking. The pathophysiology, occasionally episodes of gastroesophageal reflux are common in healthy individuals. So it's not only those who are sick that experience GERD, but also even those who are healthy, they usually have episodes of gastroesophageal reflux. The reflux is normally followed by esophageal peristaltic waves that efficiently clear the gullet. Now we have alkaline saliva that also tries to neutralize the residual acid, and symptoms usually do not occur. Gastroesophageal reflux disease develops when the esophageal mucosa is exposed to gastroduodenal contents, the contents of the gastric and the duodenum, for prolonged periods, resulting in symptoms and in proportion of cases, esophagitis. We have several factors that are usually known or to be believed to be involved in the development of gastroesophageal reflux disease. And one of them is hiatus hernia. In hiatus hernia, usually it causes reflux because of the pressure gradient is usually lost between the abdominal and the thoracic cavity, which normally pinches hiatus. In addition, we also have the oblique angle between the cardia and the esophagus. Usually it disappears, hence risking more for one to get gastroesophageal reflux disease. Many patients usually have large hiatus hernia and develop reflex symptoms, but relationship between the presence of hernia and the symptoms, it's usually not clear, it's poor. Hernia, it's a very common, hiatus hernia is very common in individuals who have no symptoms, and some symptomatic patients have only a very small or no hernia. Nevertheless, patients who develop esophagitis, Barrett's esophagus, and peptic strictures have hiatus hernia. Another factor is abnormality of the lower esophageal sphincter. Lower esophageal sphincter is tonically contracted under normal circumstances, relaxing only during swallowing. Some patients with the gastroesophageal reflux disease have reduced lower esophageal sphincter tone, permitting reflux when intra-abdominal pressure rises. In others, basal sphincter tone is normal, but reflex occurs in response to frequent episodes of inappropriate sphincter relaxation. So, under abnormalities of the lower esophageal sphincter, we say that one, you may have an abnormal response, or rather an inappropriate lower esophageal sphincter relaxation, and also others have reduced lower esophageal sphincter tone, hence allowing the gastric contents to reflux upwards to the esophagus. Another point, number 3, is the delayed esophageal clearance. If you have a defective esophageal peristaltic activity in patients, especially those who have esophagitis, it normally causes reflux disease. Another point, number 4, is the gastric contents. The gastric acid is the most important esophageal irritant. It is the one that causes irritation of the esophagus, and There's a close relationship usually between the acid exposure time and the symptoms. Pepsin and bile also contribute to mucus injury. Defective gastric emptying is another point. Point number 5. Gastric emptying is delayed in patients with gastroesophageal reflux disease, but the reason is not usually known. Also, we have another point, number 6, increased intra-abdominal pressure, such as in a pregnancy state, and those who are obese. Usually, obesity and pregnancy are established predisposing causes. But when these patients, when they lose weight, especially those who are obese, the symptoms usually tend to improve. Dietary and environmental factors, a fat diet, a diet containing chocolate, containing alcohol, tea, and coffee usually causes relaxation of the lower esophageal sphincter and may provoke symptoms. It may cause the gastric acid contents to reflux. And also food that trigger symptoms vary widely between affected individuals. So you may have given individuals when they take this kind of foods usually trigger the symptoms and experience the symptoms, but others. So that point is quite specific to specific patients. We also have factor patients around point number 7. Visceral sensitivity and patient's vigilance play a role in determining symptom severity and consulting behavior and individual patients. We have the clinical features of gastroesophageal reflux disease, and the major symptom is heartburn and regurgitation, usually provoked when one bends down or rather is straining or is lying down. That is why these patients, they're supposed to lie to raise the head of the bed, or rather lie maybe using pillow. They may experience water brush, which is hypersalivation due to reflux salivary gland stimulation as acid enters the gullet, and it's usually often present. And those who experience the water brush, usually the patients are overweight, and some may wake up at night by choking on the reflux fluid, irritating the larynx. Another point is odinophagia and also dysphagia. There is painful swallowing and difficulty in swallowing. Those patients with GERD, they tend to experience typical chest pain that may be severe and may mimic angina. It may be due to reflux-induced esophageal spasms, which include voice hoarseness, recurrent chest infections, and chronic cough and asthma. Investigations to these patients now that you may do, we have endoscopy, which is the investigation of choice. We also have to monitor the pH, and a pH of less than 4 for more than 6 to 7% of the study time. It's usually diagnostic of reflux disease. Management, how we're going to manage the patient. If the patient is overweight or rather the patient is obese, you encourage weight loss, of course, exercises, and avoidance of dietary items that some patients find to worsen the symptoms. We have also the elevation of the bed, as we have discussed earlier, in those patients who experience night symptoms, the nocturnal symptoms. Also avoid late night meals. Try to eat a little bit earlier so that by the time you go to bed, the stomach contents have gone down to the duodenum and so on and so on. If the patient also is smoking, you advise them to stop smoking. You can as well give antacids, normally 10 milliliters every 8 hourly. You can as well give proton pump inhibitors, usually esomeprazole omeprazole. You can give either of those among other in that classification, but again, we should be cautious that in the long term, those proton pump inhibitors, tend to be associated with the reduced absorption of iron, vitamin B12, and magnesium. You also have a small but increased risk of osteoporosis and fractures. You can as well give H2 receptors such as cimetidine or rather ranitidine, but again, they relieve the symptoms without healing the esophagus. Some of the complications that you're going to get when one has experienced gastro-esophageal reflux disease, we have peptic stricture, we also have esophagitis, we have Barrett's esophagus, and Barrett's esophagus is usually a pre-malignant condition whereby the squamous lining of the lower esophagus changes to columnar mucosa. Usually this occurs in about 10% of patients who undergo gastroscopy and reflux symptoms. Thank you so much. I believe you have learned something. If you have any question, you may ask and we will respond.